Well, thank you all for joining us today or this evening. My name is Cindy Pankella, and I am the Senior Director of Physician Services at the American Osteopathic Association. Our webinar this evening is an update on telemedicine, and it's for the physician. And it's all due to Medicare's April 30th release of the interim rule, the CME effect on the practice and services. So before we get started, I wanted to go over a few housekeeping rules. So housekeeping-wise, I'm letting you know that you are all muted now. You will stay muted. If you do have a question, please put it into the Q&A box. You can type that in at any time, and we will answer those questions at the end of the presentation. If you need help or have difficulties with something else or have something that you would like everybody to be able to read, feel free to put it into the chat box. The slides and the recording of the presentation will be available on the AOA's website. And to obtain CME credit, following the presentation, you will need to go back to the AOA Online Learning platform, and within the course, you will find the post-evaluation that you need to take. Now, you can take that tonight, you can take that tomorrow, whatever works for you, but you will have to do that to obtain CME. And if by chance you did not register through the AOA Online Learning, you will need to register there and then go into the course. It is still free for AOA members, but that's the way you get your CME. And our speaker for this evening is Jill Young, and those of you may have been with us previously when Jill spoke about the telemedicine codes. Well, she's back to tell us all about the changes. But Jill is the principal of Young Medical Consulting, LLC, which is a company she founded 11 years ago to meet the education and compliance needs of physicians and their staff. She has over 30 years of medical experience working in all areas of the medical practice, including clinical, billing, and rounding with physicians. Her comments and opinions can be seen in several publications and also heard on a variety of audio conferences. Her background gives her a unique style of teaching using real-life examples of coding and billing situations. She hates boring lectures, so be prepared for today's talk to have a mix of humor and a fast-paced style that will keep you engaged and informed. Her valuable advice is sought after regularly by numerous publications, webinars, seminars, and private practices. Her background gives her a unique style of teaching using real-life examples of coding and billing, and we are thrilled to have her back with us. And I will turn it over to her.
Thank you thank you so very much, and welcome to all of you taking time out of your busy schedule and your evenings. As we were just talking, the good news is that CMS continues to release information to us to clarify and qualify what we're doing. The bad news is they keep releasing information so that we have to keep getting together and learning exactly what it is we need to do. The disclaimer slide that's on most speakers' presentation is there, and it's most important because the information is only as good as a couple of days ago. There's a website I'm going to show you that they continue to update information, and so we may have gotten new information while we were talking. So just stay as current as you possibly can. Now I want to start off with the good news. I'm sure you've all heard that CMS is going to be making a payment adjustment on the telephone-only phone calls. We thought that they may waive the video portion of our telemedicine telehealth codes, but instead they're going to increase the payment for the telephone only calls, the 99441 to 99443, that are for clinical providers, which would be our doctors, MDDO, and our non-physician practitioners, nurse practitioner, PAs, and certified nurse specialists. The other codes that are used by the other practitioners, the dietitians and mental health professionals and others, the 98966 to 68, those codes are not seeing an increase, so they are still paid at a reduced level. These payment increases will go retroactive to March 1st, and CMS is going to do the work for us, they're saying, so that your staff does not need to reprocess any of these types of claims in order to get that significant increase in payment. And they've even made it nice and simple that, as you can see at the top of that slide, that the first code crosswalks to a level 2 office visit and on up from there. So just a couple of reminders of things for you to pay attention to if you don't want to read a ton. We know we have the waiver 1135, which was the start of what we're doing, and we refer to that as the waiver. And then we know you've heard of the CARES Act. And then we have these two interim final rule with comments, one that was released on March 30th and the other that was released on April 30th. And those both have numbers associated with them. Most of the information you're going to get tonight is going to be from that second one, that 5531. And I've actually tried to put the word May on the bottom of the slide so that you knew that that slide contained information that came out, in essence, the 1st of May. April just got too messed up as I tried to put that information on the slides. As we look at our telehealth services, just to go back a step, remembering that prior to COVID-19, we have services that were performed by a physician in his office generally for a patient that was in a remote site, that was in a HPSA shortage area, that had a facility charge associated with it because it was a doctor's office or a hospital. What Medicare did in waiving that distant site was they then confused us with what we were supposed to do with billing, and we had some issues because of that facility side. So now we're just billing for services, and we have to get it technically right, but the patient can be at any location. So whether they're at home, at the nursing home, or at their daughter's home, it doesn't matter. They are allowed to be anywhere, not in a shortage area, as long as you're contacting them to take care of them as their physician. Those services are going to be allowed from Medicare. And you'll notice in this bottom left-hand corner, there's the CMS.gov logo, and that is there to remind whenever I have information that is from CMS, because we do have some information from other carriers. There are a lot of different practitioners who can do the telehealth services, and again, we have to look at their state scope of license, but just as a reminder of all those that can do it. And then the place of service, your staff has been going crazy trying to figure out what are they supposed to do for which carriers, but for Medicare, the place of service they're going to bill for telehealth services is the normal place of service that you would bill for that code. So if we're talking a 99213, where would you normally bill that? Are you an office setting, so it would be 11, or are you a provider-based billing location, so it would be a 22? If you use the telehealth place of service, you're going to see that payment reduction I talked about a minute ago. And your staff, and I'll talk to them when when we do this for staff, I'll show them ways for them to go in and correct that mistake so that you can get that extra charge that you were reduced on for doing what we told you to do. Again, lots of quick action was taken by CMS, and some things just weren't quite thought through. And one of them was that you would see a reduction in payment, and that's not what they wanted. Now, I have that picture of that gentleman sitting on a phone in a chaise lounge to remind me to say, any services that you're doing that are telehealth services, you're going to bill from the location you would normally bill that code from. So if you're at home calling patients, you would still use place of service where you would normally bill those from. And that's a change from what we were told in the beginning. So if it's from home, you don't have to register your home. If you're in the car, normal place of service that you would be billing that service from is what you use. And then there's a modifier that's attached. CMS wants the 95 modifier. Other insurances want a different modifier, but basically we're just telling them that we're doing this via that real-time audio-video telecommunication system. Now that audio-visual real-time telecommunication technology, which is really the heart of our telehealth services, is very specific in that we have to have both audio and visual. And They have not changed that part of it, even though some of the press releases sounded as if they did. It was just, I think, written by someone that didn't understand how important it was to say audio-visual, real-time, two-way communication. Now, they added a bunch of services during the public health emergency, and there's over 80 codes that were added, and this is a link to the codes. This is the most up-to-date link, because not only does it give us the information for all the services, it gives us all these codes. And so if you're going to ask me a question of, you know, is an ESRD home visit covered, I'm going to say, what's the code? And if you say it's this code, I'm going to look at the list and see if it's there. And so there's 3 slides of just all the codes that are there. And you'll see on the last slide, we have these G codes. So we have our tobacco use counseling, we have our annual wellness visit. So all of these are covered under the concept of telehealth, telemedicine. Now, one of the things we want to be sure and talk about, and I think I have a slide out of order. Nope, I must have lost a slide. Okay. One of the things is that list that you have, that you would get from that link that I showed, also has a column that says, can this be done by audio only? And there are some of the codes that are audio only codes, such as the 99441 that says audio only. And so there are some of the codes that are audio only, and they are a lot of, let's see if I get a little highlighter here. They are a lot of these G codes. And so have your staff download the list and print it off so that you can see which codes can you do just via audio. Even though they're telehealth services that we just said were audio video, they have clarified that some of these services, and a lot of them are in this range here, that can be done via audio services only. Now, I also want to say at this time that this telephone only code, that is a code that Medicare stepped up and said, okay, we'll pay for this code, that it has restrictions. This code, as you can see, says it can't be originating from a related E&M service provided within the previous 7 days, nor leading to another service or procedure in the next 24 hours or soonest available. When we use the word E&M service, we have to remember that E&M services, and I think I know, yep, that E&M services, and I apologize for switching slides, but these are all considered E&M services. The E&M services section of the CPT book is not just our office and hospital visits. So any of these services that are performed are restricted in that 7-day window that we're talking about right here. So that means if you see a patient on Monday and you're going to call them later that week about that problem, that phone call will not be covered. Or if you see the patient and have them come into the office, that's the other restriction, if they come in within 24 hours or soonest available. So for those telephone only calls, you've got to watch that 7-day prior or next appointment. So that's something that's kind of come out as we've looked at this. Now, when it comes to our telehealth visits that are the office visits, the 99201 to 99215 that you're used to using, those do not have any type of frequency limitations. So if you make a telehealth audio video call to a patient on Monday, you can call them back on Wednesday for the same thing. And it's because it's a different code set and there are different restrictions. So here are the 3 kinds of codes that we are using for the most part. And again, we have almost 100 codes on our telehealth list. But basically, we have our electronic online digital ones, we have our telephone ones, and then we have that telemedicine audio visual office kind of visits. And then everything else that's on the list. The difference in these codes is who the providers are. So for example, in these telephone only codes, this 98966-68, that's for other providers that don't have the clinical aspect of their licensing, or the G2012, which is what Medicare wants them to use for telephone only codes if you're someone like a, example, my mind just went totally blank. Perhaps like a speech language person or something like that. So it depends on the provider which of these code sets we're going to look at, but that's old news. Blue Cross Blue Shield has sent out information. Here are all the codes that they're covering, and then there's billing instructions that your staff would care about, but they have certainly a significant number of codes. They did not pick up on all of the codes that other insurances, that Medicare added to their list, but this is just Blue Cross Blue Shield of Michigan and how they're doing it. If we look at Blue Cross Blue Shield of Texas, you can see we have indications telemedicine visits are covered as a regular office visit for providers who offer two-way live, interactive telephone or digital video consultations. Please note, blah, blah, blah. Please note on a temporary basis in response to COVID-19, audio-only consultations. So in Texas, they'll pay for consultations with just audio. So every carrier has their own take on these variables that we have. More information from Texas. This is what staff is sorting through, them which modifiers in place of they're supposed to use. This is Michigan's list. You can see that we've got modifiers in place of service that they're telling them how to bill it. And Michigan said that they're allowing telephone only calls for telemedicine, telehealth visits. So in Michigan, they can do and bill the 99213 and to make it a phone call. So all of these different variables that you can see, and I'm putting these up here just so you can see, your staff has a job in front of them. So even our Medicare Advantage plans, they don't have to follow what Medicare is doing. They're encouraged to, but they may follow what their home insurance is doing. So Aetna may have a commercial policy that they do this way, and their Medicare Advantage may follow their commercial policy, or it may follow what Medicare CMS does. So your staff is going to have to make some kind of a grid in order to not only find out how to bill these services, but also to find out who is allowing what. And that leads up to what you need to be doing, which is talk to your patients, take care of your patients, and then have some kind of a system so that the information is documented, and let your staff who's done the research decide what codes to use. In other words, if you have the initial contact from the patients coming through a portal and it's an email, that's one set of codes. If you have patients that are going to contact your office saying they need care and your office explains to them, here are your options, or they have an appointment and you're being explained, here are the options, then that could be a telehealth visit. And then how do you get back to the patient? And do we have the qualifiers of that 7-day visit? How do you reply? And then what do you tell them to do? And then what's the level of service of the other variables? Have all that information, give it to your staff, because the exact same scenario for one insurance could be a phone call only, like a 99441, and for another insurance, it could be a 99214. And so you don't want to be losing out on both levels of service from a reimbursement perspective, because remember, not everybody has bumped up or is paying those telephone only calls at the same level that Medicare is paying. So just a suggestion from my perspective of let your staff that's doing all this research help you in order to pick the right type of code, the right level of code, so that you can just see your patients. So what do we need in the documentation? Some of the codes need consent, some don't. So I'm saying just get consent from everybody. Some of the codes want it once a year, some of the code wants it every time. How is the contact initiated? The method of reply. You're setting the stage for the documentation for the code that you're going to pick. The total time of the visit if you're doing counseling, coordination, and care, or the total time of the encounter if we're using new time, and we'll talk about that in just in a moment. Or maybe the patient was seen within the 7-day window, but this phone call that we're making has nothing to do with that. And we want to state that in the record, because if you've got to appeal that service, that information is there in the record. So when we're talking about documenting those office visits, those telehealth office visits, like the 213 and 214, you can use time like we talked about in the old days. Boy, that sounded terrible. As we talk about time for counseling and coordination of care, where you can use your bullet points. Don't forget, you've got to make sure that you're showing medical necessity in your documentation. Or we are allowed to use something that was supposed to not happen until 2021, which is use our medical decision-making in our code selection, or use this new definition of time. Now, for both of these concepts, still a clinically appropriate history and exam should be performed. It's just the documentation requirements of that are not there in this concept. That's the 2021 concept. Now, I'm calling it new time so that I don't get confused, but that new time, the 2021 time, is the total time of the encounter, and that includes both face-to-face and non-face-to-face time with the patient. And so from the moment you open up that chart, whether it's a paper chart or an electronic chart, you're on the clock as long as you're dedicated to that patient, and then you're going to use that total time of the encounter to pick your code. Now, for right now, they just clarified that we're going to use the code, the times that are associated with the E&M codes that are in the 2020 CPT book. When the waiver first came out and the information about this first came out, they gave us different answers for what the times were. But the final, this last 5531 rule came out and said, no, we're using the codes that are published in this year's book. I will tell you that next year, these code times will change. They will go higher. If you're a teaching physician for the duration of the public health emergency, the PHE, you may not only direct the care furnished by residents using that audio-video real-time communication technology, but you can also review the services that the residents are providing during, immediately, or after the visit remotely by virtual means using that technology. So we're talking about, for example, you have a smartphone in your hand that has audio-video capabilities real time, and you're talking to your resident and you are not with them, that they are waiving, and that's the big thing that they're doing, is they're waiving these requirements. They are waiving and allowing you to not only, you know, be in communication with your resident by having that phone in your pocket and meeting the level of supervision required for several services, but they're saying you can also now pull that out of your pocket and use that audio video real-time communication technology in going through what it is that you need to as a teaching physician. Also, and you can see down here, this is with little May, that is telling me that it's new information. They also validated that these additional services are allowed by a resident under that primary care exception, and validated they are allowed to use what we just, that 2021 model of using either medical decision-making alone or the new time in selecting their level of service for an E&M for that telehealth office type visit. And then also, just as a reminder, we have for 2020 in the Medicare final rule that we have that simplified documentation that says, okay, anybody that's allowed to provide services and bill for services can review and verify rather than redocument information that was included in the record by these people. Now, the medical team is something new. So anyone that's a member of the medical team, they're saying any of their notes, I would exercise caution to make sure that there is a good trail of where that information is, so that an auditor can always find it. So again, signing and dating is they are calling review and verify. And then making sure that always we have reasonable and necessary, or we have the medical necessity documented. When we look at our telemedicine, telehealth, we are providing these services without regard to the diagnosis of the patient. I've had a lot of questions about, well, what if the patient doesn't have a COVID problem? In the very beginning, they said, we want these patients to stay at home for the services that you're going to provide, like the office visits and other services. And that means if they're calling in because they have a fever and they're short of breath, maybe that's a COVID, or they have an earache. The diagnosis does not matter when it comes to providing these services according to CMS. According to CMS, other insurances may have a little bit narrower scope. And when we talk about some of the financial aspects of it, a narrower scope. And again, notice, reasonable and necessary still has to be there and be in the documentation. Now on April 1st, we received our code for COVID-19, the U07.1. This, if your staff were to type in CDC and ICD-10 in their Google box, this is what would come up, and this is the information they need and you need for coding. And I say coding correctly, and I know I'm a coding geek and y'all make fun of me, but I can tell you that if you don't get this part right, if they have an insurance that would waive copays and deductibles, they're not going to be waiving them because they're not going to have the correct information according to the ICD-10 guidelines, which is the rules that everybody has to follow. But those guidelines are what they're basing their payment or waiving of copays and deductibles for many of the insurances. So it's very important that this information is correct. So if we have a patient that has a positive diagnosis, and a positive diagnosis to me as a coder is you, the physician, saying this patient has this illness. That a patient has COVID-19, my job is not to go looking for a lab test. My job is to code that you said the patient had COVID-19 with a pneumonia, and I'm going to use the COVID-19 code and then a pneumonia code. And in that order, after April 1st, for all patients with one exception, and those are some electrical patients. Now what I've done, and this is at the end of the presentation, it will be in the handouts that will be available to you, is because the COVID, the U07.1 didn't come out until April 1st. Prior to that, we had other instructions that we were told. And so what I did was I put the scenarios side by side. So for a pneumonia, where we have a patient with the pneumonia confirmed as due to COVID-19, from February 20th to March 31st, here's your instructions, and then over here are your instructions after April 1st. And yes, they are completely different concepts. One has the pneumonia first, the other has the pneumonia second, and that's just the way the CDC decided to do it. Also in that list of diagnoses, and this is right now for patients that are looking to get tested, or especially looking to get their antibody test, they're asymptomatic, they're being screened, they have no exposure, no signs or symptoms, and the test results are unknown or negative. This is the code that ICD-10 CDC is telling us to use. And so this is a very important code. And again, this is an April 1st instruction. All right, so supervision. I mentioned the phone in the pocket phone. The use of real-time audio and video, this telecommunication, that has been extrapolated out through many of the areas of supervision that you as providers can give. So both our NPs and PAs, and then also for your staff in the office. Anytime that you have a level of supervision that you need to require, that is required of a code or of the scenario, you're having that phone in your pocket meets that level of supervision. Now I can say that with confidence because I was on a CMS call earlier in the month, and I specifically said, not that the person has to be on the phone, but rather just the fact that we both have phones that have that real-time audio video capability, that meets the level of supervision. And they told us, yes, they did. So more than ever before, your time, they are trying to free up your time to be able to see patients and to allow some of staff, whether it is staff in the office or NPs and PAs, to operate a little bit more autonomously with you as that backup. We have 3 levels of supervision. There's personal supervision, where you have to be there specifically. We have direct supervision, where you're supposed to be in the department. And then we have a general supervision, and they have relaxed even the general supervision so that it can be as simple as text messaging. new information giving us that pharmacists during this public health emergency will fall within the definition of auxiliary personnel, and there are some codes that pharmacists are allowed to bill with appropriate levels of supervision, as long as that service that they're providing would not normally be included in a Medicare Part D or the drug benefit. Still has to be within their state scope and practice, but they're saying that pharmacists are allowed to provide these services. Diagnostic tests prior to this COVID emergency, only were allowed to provide that level of supervision for direct or personal. An NP or PA could not be the person that was in the room with a patient getting, for example, a stress test. It had to be a physician. They have relaxed that, they've waived that, so during the PHE, any of the above may provide the appropriate level of supervision. And again, it's when the level of supervision is at a direct or personal supervision level. The remote physiological monitoring codes were codes that we were just starting to get used to. These are codes that allow for just that remote monitoring. We have the first two codes that are about the initial setup, and then a device that has daily recording, transmitting over a period of time for 30 days. And then remote monitoring of services where our clinical staff time, we have our first 20 minutes and then each additional 20 minutes. And then we have blood pressure and other monitorings that are over 30-day periods. So all of these codes have come into play now, and it's sort of a compiling of all of the variables that we might be able to have that have been changed. So first of all, for these RPM services, new and established patients, and we see that in most of the codes that we're working with, that the codes, even though they may read established patient, there has been the waiver 1135 said no, new patients can happen too. Consent can be obtained at the time of service and furnished by our auxiliary personnel. So your staff can talk to the patient first and get their consent and document it in the record. Again, as we've been talking about this direct supervision, where we have direct supervision that can be through that audio video real-time telecommunication, and then patient being checked in, and then the medical devices that they have to be ones that are listed in a specific list on the FDA website. But this is a new service that was out for this year, and now it's fallen into our domain with our teleservices. Now you read 30 days, and the threshold for the 30 days was 16, but there was comments made that some of these patients, the monitoring doesn't need to happen for that long a period of time. And so they modified the rule for these codes and said, if they say it's a 30-day period, then not less than 2 days, but we could go fewer than 16 as long as it's over 2. And then some in that area are not affected by this in that 30-day realm. And then ordinarily we need to have initiating visit for this, and they're saying that we can have that via telehealth. So lots of changes. And again, the document, the 5531 document that came out is another nearly 300 pages of information. And we also have some others I'm going to show you in just a minute that you can read at your leisure. Specimen collection, there wasn't any code for offices that were going to potentially be providing this service, where we have the staff assessing the patient for symptoms and exposure, and then potentially collecting that specimen. And so in the latest release, the 5531, they're saying to use the 99211 office visit code. Now we know this is a code, we call it a nurse because it does involve an interaction with the provider or the other qualified healthcare professional. The presenting problem is minimal, and usually you're just, as a physician, you've got to be just somewhere in the office. And that part hasn't really changed, but what has changed is this is another code they're going to allow use for new patients, which it's an established patient code. They're going to allow it for new patients, but on an interim basis. So when we have the staff assessing symptoms and collecting specimens, then these are going to be incident to services to your staff and can be billed. Now, if you want to know what needs to be in the documentation, what do you think right here? When clinical staff assesses symptoms and collects specimens. That's what I recommend you have in your documentation. Now, it says that cost sharing for the service is going to be waived when all of the requirements are met. One of those is going to be the right diagnosis. And so make sure that you are familiar with when do we use the COVID codes and when the U0 one, and when do we use other codes. There were 2 other codes, and I put them in here just because I've questions. These 2 codes for specimen collection are to be used by labs and other hospital outpatient departments. It's not appropriate for them to come out of your office. We know we had 2 new codes that we just started to get used to, the store and forward and the virtual check-in, where our patients would be in touch with us. And the questions were asked, could both of these codes happen in the same day, where the patient perhaps sends in and sends in a video, sends in a photograph of something, and then we have the physician responding using the virtual check-in code, and they said, yes, it's certainly possible that if the requirements of both codes are met, that they could both be billed on the same day. And then the other probably biggest thing is this expansion of providers. So they're allowing for the PT, OT, speech language pathology, social workers and clinical psychologists to bill for these 2 codes. Previously, they had been excluded from billing from them, and so that was a change in this newest update. Now, patient initiated, this is going to be confusing, and I'm confused as well. On a phone call from CMS, they said the reason they put in that they wanted services to be patient initiated is they want offices making cold calls to patients, in essence, soliciting appointments. I understand that. But what they put in this latest rule was that we need patient initiated visits, means that the patient must consent to the service. I'm not sure the patient consenting to the service in advance of the service satisfies my definition of patient initiated, but it does for CMS. So that's why I say, you know what, let's just have consent on all of our services, even if they're not required by the letter of the code. But what's in that consent? That the patient realizes that they have a service that's an audio video service, that they're consenting, that they understand that it is a service and they have financial liabilities, and whatever else you think is common sense, because guess what? They haven't defined what consent is. So have a policy. What is your staff's spiel that they're going to give to the patient on consent, and then the staff can then document that they got consent from the patient. And also, we want to put in, if we said to the patient they had an appointment and we called them to verify the appointment and gave them the options of here's how we can do it, and they chose an option, that's allowed, giving them information. But rather what they're saying is they just didn't want doctors, as they called it, making cold calls to patients. And again, that's what they gave us in our news release. Another piece of new information they gave us, that if the practitioner, you say that the patient is homebound, we do not want this patient coming out of their house. They are at high risk, much more susceptible to contracting the COVID-19. It's medically contraindicated. I'm saying the patient is homebound, then that's good enough. And as a homebound patient, as you well know, that there are many services that become available to them as homebound patients. So this is a good thing. Also, in our home health arena, they are allowing our nurse practitioners, physician assistants, and certified nurse specialists to do things they've never been allowed to before, which is to certify, establish, and then revise the plan of care, as well as supervising the whole provision of it. And so again, trying to get more providers out there that have 100% operability in taking care of patients. They also are allowing PTs and OTs that are supervising PT assistants and OT assistants, they are allowing them to up their game in allowing them greater access to care as well. And so the PTs or OTs are establishing the program for the patient, and then that in turn is being delegated to something that the PTA or OTA is going to be in charge of. Now, one of the questions that I have gotten that was in one of the frequently asked questions that's come out is this, and this is a direct quote. We note that clinical staff are auxiliary personnel. And I don't think that CMS is changing their mind in saying that, because many of our states where MAs are not licensed and therefore they do not qualify as clinical staff. I think rather they're just saying that there are times that auxiliary personnel can do things. It's not that clinical staff can't do them. That clinical staff can sort of step down, if you will, an RN can step down and do something that normally an auxiliary personnel would do. We're trying to get this clarified. Again, people have raised it as a question, especially here in Michigan, where our MAs are not licensed and therefore can't be clinical staff. Whew, I talked fast. I took out some resources and I apologize. I thought I had them in there. I must not have. Let me just check. Are they still behind? Nope, those are our ICD-10 codes. If you go to the current emergencies website on the cms.gov, all of the frequently asked questions, all of the information that your staff is pouring over is there. Just you necessarily go out and read it. I'm just telling you where it is. And that's also where you can find both of these final rules that have come ad nauseum. And again, when we talk about this again next week with staff, we'll give them more detailed information. But from a provider's perspective, I'm going to turn this back over to Cindy and ask her if she would help us with some questions.
Okay. All right. So we do have one question that came in. Can you further address the documentation specific for telephone audio only visits, including where the different lengths of visit fall, i.e. how many minutes equal what level of service? Well, and then she asked for how much is reimbursed for each level, but we know that that varies.
Okay. When we look at, and I assume we're talking about the 99441, 442, and 443. They all have a specific amount of time associated with them. Because of the type of service they are the kind of code that you have to meet or exceed the base time. So those codes, and hopefully I won't get your car sick, those codes, I think the first one is 5 to 10 minutes. You have to get to the minimum threshold. You have to get to the 5 minutes. It's not where you can get halfway, where we can on some of the other codes that we work with. So the minimum threshold of time is the minimum that is shown with the code. It is not halfway or anything else. So the 99441, you have to 5 minutes to bill for that code. And you know, whatever documentation, however you want to put that information in, that's what you put in. If you get minutes, and I know you're going to ask me the question because it says 10 minutes and then it jumps all the way to 11. Remember I said you had to meet the minimum threshold, so that means you have to get to 11 minutes. So if you're at 10 minutes and 52 seconds, I would say talk a little longer and get to that 11 minutes. But there's no requirement on how to document that time. It doesn't stop. It's just that anytime you have a time-based code, you want to make sure to document at a minimum that you met that threshold by saying how much time did you actually spend.
Okay, and the next question was, do you need a full progress note? Obviously, you just answered that. And then, must there be documentation as to why the patient cannot do a telehealth visit instead? Most of my patients are in their 90s and many of them only have a landline or non-smart mobile phone.
Right. And no, they don't, because these are, and that's the beauty of them allowing these only codes. We don't have to justify why we didn't use the other codes. These codes are paying the same as our office visit codes on the other side. So that crosswalk that we had at the very beginning where the they're paying like 11.4. So I lost my train of thought on that. But no, just document what you're doing, document that time, and there's no reason. And I think they realized that Medicare patients are over 65 and older, and they either don't have the technology or don't have the knowledge to use the technology. So thanks, Cindy.
Okay, and then can you provide an example of what should be in your telemedicine patient consent? And then should you just create a form for that, a standardized form?
Prior to this, there were forms that were required to be signed in advance. So verbal consent is allowed during COVID-19. Those forms, looked at several of them because I've been talking about telehealth and telemedicine for COVID. Some of those consent forms had language that, I apologize, but lawyers must have come up with. There is nothing that I have found in the regulations that say anything about what's supposed to be in a consent form, other than in a couple of places where they say that they understand that it's a visit that they may have financial liability for. So yes, I would have a policy for what your staff should say when they gain consent. And I would say, use your common sense. If it was your mother who's 90 years old and you want to be sure that she understands what's about to happen, that's what they should say. But there are no specific information that I've been able to find, and this is, you know, pre-COVID and now, that says what exactly consent is, other than that they realize that there is a service. And again, you can go out on the internet and find 2-3 page forms. I don't recommend doing that. And again, nothing that I've seen ties to those kinds of forms.
Okay. And basically on the patient encounter as well. So for the document consent, is the patient staffs the room, or if it is a telehealth visit, are they should the staff document saying that the patient is agreed for telehealth, or does it have to be the physician?
No, one of the waivers that came out was that your ancillary or auxiliary staff can document consent. And so I'm going to guess that in many offices, perhaps the staff is getting the patient on the phone and can gain consent at that time before they turn the call over to the provider. And again, that I would have them put a note in the chart, whether it's a code that requires consent, whether it's a code that requires it once a year, or whether it's a code that requires it every time. I would just say, just get it every time as a rule of thumb, then you won't be wrong.
Okay, well, that looks like the end of our questions. If anybody has any else, please type them in. Jill, can you go to the resources slide?
Oh, yes. All right, we're gonna have to go speed time here.
I just wanted to talk to you tell you some of the upcoming webinars that are coming up in case anybody wanted to register for them. Yet there is still time. Tomorrow evening, there will be for the contracted employed employed physicians. Well, first we'll go here. Physician support line. Obviously, you are not alone out there. And if you are feeling that this pandemic is hitting you a little bit and you need someone to talk to, please contact them. You're not alone. There are people that can help you. And then our next slide. Osteopathic.org is the COVID-19 page that is updated regularly. Our communications team is diligently working on putting things up that they get from both our department, from the public policy, and from all the same information that's out there with that you're seeing. We're condensing it all into one place for you. Next slide. And then these on-demand webinars, Jill's previous webinars on telemedicine, if you didn't see them, go on and look at those, as well as billing and coding a little bit. And then the CARES Act, if you need to get more information on that. There's a bunch of other on-demand webinars there that we have. Feel free to take a look at that on that URL. And then the next one is our updated one. So the 28th, we have the updated telemedicine coding and billing, and that is going to be similar to what you heard this evening, but it is going to, Jill is going to focus it more for the biller and coder. So in some of your offices, that may be you. In others, please invite your staff. That is one of the reasons why we're keeping these webinars free for AOA members, and they're free for the staff. So please make sure that your billers, coders, or you yourself come back and join us on the 28th. The 29th, we have an impact on employed physicians. And then June 3rd, we're having the COVID-19 related concerns, ask an attorney. And then updating your partnership shareholder buy-sell agreements on June 10th. And then we're working on a reopening your medical practice toolkit as well as a webinar. And those will all be available on that URL. And then again, if those of you wanting CME, please go back to the AOA Online Learning platform. If you do need to register again, fill in your AOA username and your AOA password, and that should get you in. If for some reason you don't have that, or you are not a member, you can set up an account to get into the AOA Online Learning to get your CME. And then as always, you can contact us at Physician Services Department. Should you have a question for Jill that you think of after the fact, please reach out to Jill herself or contact me through this phone number or the email, and I'll be sure to get that message on to Jill and we'll get an answer to you. So I thank you all for joining us. Jill, again, thank you, and we'll talk to you again next week. So,
all right, thank you. And keep your chins up. They're giving us the information we need and getting you the financial reimbursement that you deserve on those calls. So I think it's a good step in the right direction. We just have to fill in all the other cracks that we have.
All right.
Thanks, Cynthia.
Thank you all. Bye-bye.